of Barrett's esophagus. It can evaluate for Helicobacter pylori, the ulcer bacteria. It doesn't play a big role in reflux disease, but while we're down there, we can check for that. A lot of patients may have had concurrent ulcer problems over the course of their lives. We can biopsy. Big advantage. We see lining that doesn't look right, we take a biopsy. We can evaluate very carefully for Barrett's, for tumors, and for other abnormalities of the esophagus. And we can do therapeutic things. We can dilate the esophagus. If someone has a stricture, we can stretch it. We can make them feel a lot better. We can stretch other things in the esophagus that can cause food to get stuck. It's immediate relief. It's very gratifying for us. I want to go over two more test tools that we're using more now because they're really playing a role with anti-reflux surgery. One is the 24-hour pH monitor. And whenever I tell a patient about this, I get a dirty look. It involves placing a very small, very soft plastic probe through the nose into the bottom of the esophagus. And this probe can measure pH. When acid is very low pH, when acid comes into the esophagus, the pH drops very, very suddenly. And this instrument is very, very accurate at measuring those drops in pH. It's a great tool. It's a great tool in assessing patients who you're not sure. Is this patient all reflux or is there something else going on contributing to their symptoms? Especially if that patient is considering things like surgery. You can correlate events. The patient hits an event monitor. Boy, I have heartburn. Let me mark that. They can hit an event monitor, and I can see on my tracing whether that event of heartburn or that the patient's symptoms coincided with a drop in the pH in their esophagus. There's scales. It's objective data. We have a Demeester score. We can actually tabulate the results on a 24-hour pH probe and tell you if you're a bad refluxer based on a score. We can give you a number. If it's over a certain number, you reflux bad. So it's an important tool, especially in patients where you're not sure of the diagnosis. If I endoscope someone and I find erosive esophagitis, I don't need a 24-hour pH probe. But otherwise, it's a valuable tool. And along with that, and lastly, is esophageal manometry. Esophageal manometry is measuring pressure in the esophagus. This is not a tool to diagnose gastroesophageal reflux disease. It's a tool, it's an instrument, it's a test used very, very commonly to assess patients with atypical chest pain, to look for some muscle problem in the esophagus. It's also a test that has to be done before surgery, anti-reflux surgery. Before you recreate a valve, before you tighten up the sphincter at the bottom of the food pipe, you better make sure that esophagus muscle works right, or that patient's not going to be able to eat. And this is what this test assesses. It assesses, we want to see normal esophageal muscle function, the propulsion of the esophagus normal before we would recommend surgery in someone. It's done. It's not a very uncomfortable procedure. It's done with the patient awake and uses, again, a small probe. Heidi Taylor, who is our nurse in endoscopy here at Boca Community Hospital, is trained in this procedure. She's superb. We offer this procedure here now. She does our 24-hour pH and our esophageal manometry testing. And she will have you feeling incredibly comfortable with this procedure. She's really good at it. And if you have any questions, by the way, afterwards, Heidi will probably be around for a few minutes. I'm sure she'll be able to answer some of those for you. That's the majority of the testing we do. We do some other testing in certain situations. We may assess the stomach's ability to empty to see if that's promoting sense of fullness or even attributing to reflux disease. That's a nuclear medicine test. But for the most part, what I just outlined for you is our tests. I want to conclude my portion of the talk now. I'm going to, have Dr. Wilkin come up, and he's going to go over some of the surgical treatments. This is a new and exciting field, surgical treatment of reflux disease, because it's a lot easier now. And I'm sure he's going to have some interesting tidbits for us. Dr. Wilkin, thank you.
Thanks, Vito. So you've already been to see Dr. Proscia or Dr. Zwick, and they put you on some medications, told you all about the lifestyle changes, and maybe your reflux is a little bit better, maybe it's not. For the most part, the medicines do work. They work quite nicely. But maybe you're 40 years old or 30 years old, and you have to look forward to a lifetime of these medicines. And they tell you need an operation. You need to have a laparoscopic operation. And the first thing is, oh, my God, I need an operation. That's a horrible thing. But, what is a laparoscopic operation, and what is the Nissen fundoplication, which is really the procedure, for the most part, that we do to correct reflux. What Dr. Proscia described is that he told you that reflux is basically the fluid, the effluent in the stomach contents goes up through and into the swallowing tube, into the esophagus. Well, that's a mechanical problem. And surgery is the art and science of treating mechanical problems with fixing the mechanical problem. If you can't find a mechanical problem, usually you can't fix it with an operation. You can decrease the acid with the medicines, but you're not going to decrease the